Otherwise, we'll get started with the first series of talks, which is, so they're broken up into 40 to 1 hour minute sessions. First one is on spinal modulation for rehabilitation. And we have two speakers, Dr. Daniel Liu and Dr. Reggie Edgerton. Dan is associate professor in neurosurgery and has been doing work both with invasive and non-invasive modulation, primarily focusing on upper extremity function. And then Reggie Edgerton, who you all probably know, has been working in this field for a long time with animal models. And if you saw some recent press about people who are being rehabilitated, I think all of that is really premised on the work that Reggie did to get it into a clinical trial. So, another nod to all the outstanding work that's going on at UCLA. So we're looking forward to the talks. I think Dan is going to speak first. Thank you very much.
Thanks, Nader, for that introduction. Obviously, my time with Reggie, who is a close collaborator of this, the first part of the talk is our work on upper extremity function, and later on we'll talk about the autonomic function as well. So as a neurosurgeon, I publish a lot on how to do surgeries to treat spinal cord injury and conditions like that. We put in a lot of effort. Our 7 years of residency training is directed towards how, exactly how to do that. And there's a lot of effort and a lot of money spent in just the stabilization aspect of it when the patient just comes in to be stabilized. But in terms of all that effort that's actually put into that, it's actually pretty disconcerting in terms of how it does not really impact on the recovery of the function of these patients. So if you look at this, which is published in 2008, these are recovery curves based on their injury grade. So it goes from ASIA A to all the way to ASIA D. In patients who are ASIA A or B, who are motor complete, you can see that their injury recovery curve is actually pretty dismal. There's really not much of recovery of function after initial injury and stabilization. So we're spending a lot of money up front here, but really not a whole lot out here. And really currently the treatment paradigm is that the decompression and stabilization in terms of what I do as a neurosurgeon really does not improve function. And this is borne out in this Bible that we actually all use in neurosurgery, which is operating on a patient with complete spinal cord injury does not result in significant recovery of neurological function. So we essentially, the message here, at least for us, is that you can operate on them early or late or whatever manner you want. There's really no recovery of function. It doesn't impact on the recovery. So the main problem, I think, to look at this is that the spinal cord is actually very, very high real estate territory. Within this organ, which is about ½ an inch, there's probably 50 anatomical tracts, 1 billion neurons, and 7 trillion connections. There's countless descending and ascending tracts, efferent and afferent tracts. And injury of these tracts would cause substantial dysfunction. And this, just as a kind of comment on stem cell therapy, currently the stem cell therapy as it stands now, it's really difficult for me to imagine that it's going to reconstitute all these spine tracts all in this ½ an inch territory. So looking at this from the other side of the coin, which is that it is very elegant and eloquent organ. However, the spinal cord injury is never anatomical complete. And novel treatment may reinforce alternative pathways because there are so many tracts and efferent and afferent pathways that there may be potentially preserved pathways, and that may potentially serve as ways to re-enable spinal cord function. And then the other observation that spinal cord is smart and automatic, and complex motor behaviors of extremities are largely controlled by network within the spinal cord with minimal input from the brain. And actually, Reggie likely will speak to more of this aspect. And he's one of the pioneers in that spinal cord mechanism and circuit related to motor function. So looking at this from this perspective, you look at it, after spinal cord injury, you do have substantial loss, but there's actually substantial spare tissue as well. In a spinal cord injured setting, it's never anatomical transection. You never often see that. You do see that, in bullet wounds or knife wounds, but oftentimes it's not it's not a complete transection, and you do have spared areas. And these are spared tracts that can potentially lead to attenuated signal from the supraspinal aspect that can be either modulated to be increased, or the receptors or the receptive motor neurons can actually be further activated to actually execute a movement. The first topic that I'd like to address is the hand function. And why study hand function? Because the majority of patients suffer from tetraplegia, and restoration of hand function is cited as one of the highest priority in spinal cord injury surveys. Improvement in arm and hand function observed within the 6 months time period. However, there's minimal improvement after 1 year after physical therapy and training. And the hypothesis that I'd like to address is whether cervical motor network related to upper extremity function can be accessed by epidural stimulation in spinal cord injury to improve motor function after spinal cord injury in patients. So epidural stimulation is an FDA-approved device that is implanted in patients with chronic pain. We've readapted this device for the treatment of patients who have a spinal cord injury. And this involves implanting electrodes in the cervical spine, and also a battery that's actually remote controlled into the flank or the abdomen. So we selected 2 subjects that have spinal cord injury that's non-transected and have, on the axial scan, there shows that there's sparing of tissue. They're both motor complete but sensory incomplete patients. One is C5 and the other is C6 level of injury. And we use this hand grip device to test their hand function. And these are various EMG devices that we can capture their electrical activity of their muscles during a contraction. So these 2 subjects are implanted. You can see the electrode on posteriorly there and there. These are the instrumentation that they had for their treatment of their spinal cord injury for stabilization. These highlighted gray areas are the anode and cathode pairs that we actually mapped out to show that they're able to access the circuit for upper extremity function. And here you can see that these various different muscles, that hypothenar, flexor digitorum, biceps, in various different configurations. These are the pairs that we use, minus 11 and 12, shows that 15 and 6, actually 13 and 14 shows most robust recruitment of these muscles in the hands. And so that's the pair, electrode pair that we actually use. So these are dose response of the location, and we increase the intensity, showing that there's actually evoked responses from these motor pools, showing that potentially, if we target these areas, then potentially we can improve function in the hands. And the same goes for subject 2. We did the same mapping strategy to obtain that. So using this electrode pair, we actually applied it in a chronic setting to the patients while we do rehab training on the hands. And so we mapped out what the optimal frequency is and the intensity for this particular subject. And you can see that the force, we have to ask the patient to generate the force in the hands, and you can see that they're at 20 or 30 hertz, they're able to generate probably the most optimal, maximal force. And then we also mapped the intensity that showed probably 1 or 1.3 milliamps demonstrated good response. And that's the second subject. We also asked them to trace the sinusoidal wave to look at their accuracy, and again, 20 hertz appears to be the most optimal. And then in terms of response times, these patients actually have delayed response to a command to activate their muscles, and it demonstrates that in terms of frequency, 20 to 30 hertz actually showed substantial decrease in the response time. So given that, we actually trained them. So we used 30 hertz frequency at 1.0 milliamps and trained them throughout this period of time. This is sham training in which we imparted about 5% of the stimulation and demonstrated that they're actually pretty stable in terms of their hand function. And during this period of time, they actually received a lot of rehabilitation intensively. And after 14 weeks, actually, we subjected them to this paradigm where we actually stimulated them. And you can see that gradually you can observe that the force actually increased in terms of their ability, hand ability. And this is without stimulation at baseline. So their baseline ability, even without stimulation, increased substantially so. And then this is with stimulation, which is the curve, which shows that there's more improved gains. 20 newtons of force is usually the force that we would like to get the patient to get past, because that allows them to grip an object, potentially turn a door handle, and whatnot. In terms of hand control, I alluded to this before, is that if you ask them to trace a sinusoidal wave without the stimulation, they're able to do it, but not in a very good manner. And while you actually ask them to, with the stimulation on, they're actually able to trace this wave much better. And in terms of endurance in terms of endurance, we actually ask them before stimulation, after stimulation, to go above and below this line in as fast manner as possible, to oscillate above and below in a controlled manner, and they're able to do so with the stimulation. And just a little bit about the mechanism. I won't go into too much about the mechanism. This is not a tonic effect where the stimulation is on, you activate the whole musculature. This is actually a modulation effect to the motor circuit. And you can see that with stimulation, the EMG appears to be larger. And the pattern of stimulation is that it actually has its own morphology. So it's not an active tonic stimulation that activates a motor pool that causes contraction of all the muscles. It's actually very discrete modulation that the motor pool is activated distinctively to the task that the patient's able to do. And this is the functional outcome. This is for those people who say, well, you're activating the hand function. Yeah, that looks great, but how does that impact on the daily living? And you can see that with the stimulation on, at the conclusion of the study, there's substantial improvement in terms of the ASIA scoring system. And the spinal cord independence measure, which measures respiratory function mobility in toilet and outdoors, it shows in significant improvement. Now, tricep strength, which is C7, is a very important muscle in terms of these patients with spinal cord injury, because that allows them to transfer, use a wheelchair more efficiently. So we can see that getting 3 out of 5, or even in this case 5 out from a strength of 2, which is below anti-gravity and twitches, to 5, that's actually pretty substantial. And that impacted, as you said, as we alluded here, the spinal cord independence measure scores of these 2 subjects. This is a picture. There's limitations of showing these pictures because it really doesn't tell you what's exactly being done on these patients, but nonetheless, with that in mind, this is him trying to grip, and it's a tenodesis grip, trying to displace the hand grip, and it's very difficult. In this case, he actually has a little bit more intrinsic, able to activate the hand grip muscle. This is asking him to oscillate voluntarily, so he's activating the muscle, his muscles voluntarily, above and below those 2 designated lines. So it shows that there's some improvement in terms of the hand function per se itself, and also in terms of the functional scores. And this is where I think the important part about this is that it not only makes for that good video, but it actually impacts on their motor score and also their function. In the spinal cord independence measure, you can see that this is the traditional curve of what a patient should be after spinal cord injury. And these 2 subjects, they're all about 20 weeks after injury. You can see that they actually are no longer in that type of curve, that recovery curve that we see. So, and both in the spinal cord, the ASIA score and the spinal cord independence measure. We moved beyond those 2 patients. We implanted 2 other patients under the auspice of an NIH grant. Currently, these injuries are all very different in every single individual. So we're finding out ways to properly map them and properly implant these and use the appropriate electrodes to improve the function. The previous study was not completely shammed. In this case, it's a triple-blinded study in terms of seeing if there's an effect. And you can see that without stimulation, the force of this subject, whose implant is below 5 newtons of force, during sham, it actually is about the same. And with treatment, under treatment conditions, with this mapped, using this AR4-CR5 electrode pair, there's improvement in the hand function. So it looks like we're designing algorithms to focus on what the residual motor pool looks like and residual connection looks like, and we're using that algorithm to see if we can get further improvements from these patients. So in summary, modulation of cervical spinal cord can be performed to enhance motor function of the upper limbs after chronic spinal cord injury. neuromodulation of cervical spinal cord can enhance both strength and motor control. And the mechanism of action likely relates to increasing activation state of the spinal circuitry. And I'll leave Reggie to expound on that during his talk in terms of some of his studies and also the animal studies as well. So the sort of the downsides, I won't say downside, but currently it's unclear whether all this effort in terms of implantation and subjecting the patient to all this risk is worthwhile, simply because it is in surgery for these spinal cord injury patients. The patients are somewhat fragile. So we don't do this without that in the back of our mind, and we are always going after functional improvements, and that's certainly some of the focus for these type of studies and going forward is it worthwhile to implant and subject these patients to all this risks, all to just show that they can move their hands. And if they can move their hands, doesn't necessarily mean that that impacts on their quality of life at all. So that's something that we really need to keep in mind as we go through these, as you listen to talks throughout the day today. Just because we can do it and we can implant all these fancy brain-machine interface stuff, is that worth the effort? And so you really have to document that there's functional improvement and that the impacts on their quality of life, and that's going to diminish improve their independence and diminish their dependence on caregivers. So I'm going to switch gears to autonomic function. So because we can actually modulate something as complex as hand function, presumably in terms of autonomic function such as a bladder function could be something that's more easily modulated and potentially improved. Bladder function in spinal cord injury, there's essentially only two muscles that you have to focus on, which is the detrusor muscle, which is on top of the bladder, and the urethral sphincter muscle, which is actually the gateway to urination. So those are only two muscles that you need to be aware of in spinal cord injury. And after spinal cord injury, there's a condition called detrusor sphincter dysynergia, where both muscles are in spasm and they co-contract. When that happens, the urine goes to the pathway of least resistance, which goes up to the refluxes up to the kidneys, and potentially could cause sepsis and kidney failure. So that's a pretty devastating condition. So the treatment currently is using catheterization. I'm just going to skip through a little bit of this, but you guys can certainly come up and talk with me afterwards. But bladder function is important. We published a study in which we were able to select about 5 patients with anatomically incomplete injuries, but motor complete injuries with this condition called DSD, or detrusor sphincter dysynergia. Essentially, these patients, through magnetic stimulation and non-invasively, you can actually induce micturition or voluntary urination through 14 weeks of treatment. They're actually able to urinate without stimulation on their own after that. So before stimulation, you can see that this is a urodynamic study showing the bladder filling, and you ask them to urinate, there's no flow through that. But after treatment, you can see that this is a urodynamic pressure diagram. It shows that there's actually now flow. I'll just skip to the last slide just to show you what happens with this. So these are 5 subjects in terms of the voluntary urination. This is an assessment period of time using low frequency simulation. You can see that after 4 trials, this subject actually able to demonstrate voluntary urination up to this point. And we did actually, the response is variable. There's a subject E that shows minimal improvement, some improvement, but not as robust as the other subjects. And you can see that the urine stream improves, the bladder capacity improves, the residual volume decreases, cell catheterization frequency decreases, and the sexual health inventory score for male actually improves. And the quality of life score also improves. So it shows that this non-invasive way of treating the spinal cord injury can be effective in this pilot trial. So these are ways of modulating the spinal cord without, I'll leave Reggie to discuss the potential mechanism. But this is a novel, non-invasive way without subjecting the patient to a lot of potential risks to re-enable function and restore independence and function in their daily lives. Okay, great. Thank you. Go ahead.
Yeah. Hi. In terms of the regarding the last study you did on bladder control, I was just wondering, I know it's 5 patients, so it's difficult to say, but do you have a hint on what could have been causing that difference in performance? Would it be the time since injury, or would it be like type of lesion they had? Again, I know it's 5 subjects, but I was wondering.
I think, no, it's too early to say, but the 2 best responders, one was 13 years from injury, and the other one was like 5 years. So it's not the chronicity of injury, unlikely to be that. It could be the amount of spare tissue, also potentially what their sensory preservation is. So there are several things that we're looking at right now. It's just too small of a sample group to derive any potential, and we are doing larger studies to address what exactly you asked. Who are the best patients that can respond to this strategy? Yes, Bruce.
Is this working? Oh, yes. So over the last 30, 40 years, a variety of ways to get people to take steps, standing and walking, who are paraplegic, people to make use of the upper extremity with cervical spinal cord injuries have come about. Going back to Wayne State, going back to the parallel walker, which basically stimulated 3 or 4 muscles in each leg, and allow people to slowly take steps over ground. And the freehand, which put electrodes into the muscles that will allow for elbow flexion, extension, wrist flexion, extension, or intrinsic hand muscle function, depending on how many wire electrodes you put in. All these groups became commercial companies, and they all died. Because patients, it turns out, we're very excited, but as clinicians, about trying to increase actual function, not strength, but actual function. And a surprising number of people don't want to put up with the complexities of these things, the side effects. And in some cases, physicians are to blame for not trying to promote those things that you just don't know enough about. And these interventions are really complex and far more invasive, with well-known complications. So, for example, someone with a cervical injury, you get epidural abscess, and you could lose 1 or 2 levels of function. It would be disastrous. So there are not only ethical issues here, but sort of trying to wrap your arms around what is it that most patients with these injuries will want. If there were 100,000 people who might have considered using the freehand, there were a couple of dozen who actually did it. And that wasn't nearly as invasive. I don't know what the answer to this is, but it's clearly something we have to be thinking about. Even achieving walking over ground, if it's very slow and effortful, you're still going to use your wheelchair most of the time. Regaining a little bit of extra strength in a hand that doesn't allow you to actually, bring the glass to your mouth or transfer better from your wheelchair isn't going to be very exciting to people, and will never be a way for us to promise that we'll be able to accomplish that. So I'm throwing this out, not to throw a wet blanket on things, but to remind us of the realities of people with spinal cord injury who are highly disabled. We only see the people who are really gung-ho, who are willing to move to a new city just to participate in a trial. There aren't a lot of those people, from what I can tell.
No, I fully understand that, and that's one of the reasons why we're going after functional improvement, and that's exactly it. Is that there's a lot of engineers in the audience right here. Just because you can implant a brain-machine interface doesn't mean that you ought to do it, and it doesn't mean that it may impact on the quality of life of these patients. So I fully acknowledge that possibility, and certainly that's something that we strive towards to impact patients in a meaningful way without subjecting them to undue risks.
Thank you, Dan. So just to remain on time, we'll move on to the next speaker.